What you are about to see are 3 interactive computer video disc simulations for medical education. Interactive means there is a continuous two-way communication between you and the program. You can tell the program what information you want, and it will respond immediately with patient history, diagnostic choices, and medical advice. This is possible because a small but powerful computer interprets your choices and presents you with the materials you need. A recent technical advance, the video disc, is being controlled by the computer and can display any of thousands of images in any order in just a few seconds. The combination of these media lets us construct realistic simulations with patient interviews, consultations, lab tests, and treatment choices. These diagnostic challenges were designed by our board of subject matter experts, led by Dr. James Freston of the University of Utah. Dr. Freston.
I'd like to welcome you to a project my colleagues and I consider to be very exciting. During the course of this program, you'll have the opportunity to diagnose 3 new patients: Mr. Miller, Mrs. Jackson, and Mr. Grant. Each patient has a gastrointestinal disorder that you'll have a chance to diagnose. The cases represent a wide range of difficulty and will have something of interest for many specialties. The format of each case is the same. By entering your selection on the keypad, you'll receive the information you request on your patient. When you have sufficient information, you can select a final diagnosis and treatment. The program will tell you the results of treatment and then give you feedback on your sequence of choices. We hope you won't hesitate to explore the program and experiment with it. Following each interactive simulation, you'll see the sequence of diagnostic and therapeutic steps my colleagues and I have followed. Our recommended sequence will also be available to you as you work through the simulations by means of the Diagnostic Consult button on the keypad. This project demonstrates the feasibility of the video disc for continuing medical education. You'll have several opportunities to record your ideas and opinions. I hope you'll take the time to tell us your reactions so we can update and improve the program. As you explore the program and think about new applications of this medium, I'm sure you'll agree with me that it offers some exciting prospects for medical education in the years to come.
Doctor, I've had this burning hunger pain right here for about the last 2.5, 3 weeks. And I'm not throwing up or anything like that, but sometimes my stomach hurts for maybe an hour or two before it stops. I wasn't even going to bother coming in here about this because, well, a few years ago I had a pain like this, and it went away in just a few weeks. So this time I thought it was probably just too much coffee and cigarettes. I've been drinking about 5 cups a day, smoking a pack a day. I even tried cutting down, but that didn't help. I don't know, maybe I'm just getting older. My body's changing, you know what I mean? For the last 10 years or so, I've been burping a little more. I've been a little more, you know, constipated. But I haven't felt like I was in that bad a shape. My appetite's been good. I've even gained a little weight in the last 3 months. Maybe I just need some prunes or something, you know. My whole family's always been really healthy. But to tell you the truth, Doc, I'm a little nervous about this whole thing because a few years ago my mother died of stomach cancer. And I hear that you can catch that anytime, or you can get it anytime. It's funny, you know, I used to just love to stop on the road and have a few beers with the guys. It's the kind of thing that you think you're going to be able to enjoy for the rest of your life. Right now, that just doesn't seem like such a good idea.
This patient appears to have a chronic gastrointestinal disorder. The character and location of his pain will provide information that is extremely useful in determining its origins.
Doctor, I've had this burning hunger pain right here for about the last 2.5, 3 weeks.
Epigastric pain usually indicates disease in the distal esophagus, stomach, duodenum, pancreas, and occasionally spleen, gallbladder, and liver. Epigastric pain is not generally caused by disease elsewhere in the small bowel or in the colon. Epigastric pain with a burning quality or resembling hunger is usually indicative of acid-related peptic disease.
My appetite's been good. I've even gained a little weight in the last 3 months.
Patients with gastric cancer and pancreatitis often lose weight and appetite. In contrast, patients with peptic ulcer disease may gain weight because they learn that eating relieves their symptoms. Consequently, it is important to establish if a pain-eating relief cycle exists. If eating causes epigastric pain, this would favor gastritis, pancreatitis, gallstones, and the irritable bowel syndrome over peptic ulcer.
For the last 10 years or so, I've been burping a little more. I've been a little more, you know, constipated.
Belching and constipation are relatively unimportant symptoms. They occur often in the general population and usually indicate the presence of incidental irritable bowel syndrome.
So this time I thought it was probably just too much coffee and cigarettes. I've been drinking about 5 cups a day, smoking a pack a day. I even tried cutting down, but that didn't help.
The history of drinking coffee and smoking is not of critical importance in an individual patient. Patients who smoke cigarettes are twice as likely to have peptic ulcer disease as those who do not, although ulcers also occur in non-smokers. Coffee, with and without caffeine, stimulates gastric acid secretion, but the most recent studies have not demonstrated that ulcer occurrence correlates with coffee consumption. Contrary to popular belief, alcohol consumption is not correlated with ulcer occurrence, except in alcoholic cirrhotics. Another myth is the belief that diet plays a role in ulcer development. Mr. Miller's description of a burning hunger pain in the epigastric region indicates an acid-related peptic disease. We need to investigate timing and function through specific history questions.
We now have all the information we need to establish a diagnosis. There's burning epigastric pain, especially when the patient's stomach is empty. The pain's relieved by food and antacids. There's blood in the stool and mild anemia. The upper GI series showed an abnormality in the duodenum that's compatible with chronic or acute ulcer disease, and the endoscopy disclosed an ulcer crater. There are two established modes of therapy for duodenal ulcer: intensive antacid therapy and treatment with an H2 receptor antagonist. They appear to be equally effective. Antacid therapy would be suitable in this case. Many patients, however, dislike the inconvenience of large, frequent doses of antacids and discontinue therapy prematurely. Treatment with an H2 receptor antagonist has been shown to accelerate the healing of duodenal ulcer disease. In this patient, the pain disappeared promptly after treatment with an H2 blocker.
Mary Jackson is wheeled into the hospital in obvious distress. We are dealing with an acute condition.
Doctor, my stomach, it hurts all over. I'm not usually a complainer, but I can't make a move without it hurting. Even the ambulance ride over made it worse. The pain woke me up this morning, and it keeps getting worse.
Thus, the pain should be characterized as severe sudden epigastric pain exacerbated by movement.
For the past few weeks, I've been having pain in this part of my stomach, especially when I've missed a meal. But that always went away when I drank milk.
The patient draws a correlation between the previous pain and missing meals. This suggests peptic-related disease. One should further investigate the pain of the last 2 weeks because complications of peptic ulcer disease could lead to the current symptoms. The patient's condition is critical. Free air in the abdomen, accompanying physical signs of diffuse peritonitis, demands hospitalization, intravenous fluids, antibiotic coverage, and immediate surgery to correct the abdominal condition. At exploratory laparotomy, a perforated anterior duodenal ulcer was found and oversewn. Mrs. Jackson was placed on intravenous cimetidine and discharged 10 days later on oral therapy. She was doing well after her operation. Then, 3 months later, developed sudden acute abdominal pain.
Doctor, I felt really fine until last night. Then about 2 hours after dinner, I developed a sharp pain right here that kept getting worse and worse.
Epigastric pain should bring to mind the same etiologies involved in the first diagnosis. In an acute abdomen or diffuse peritonitis, the slightest irritation or stretching of the peritoneal surface produces severe pain. Consequently, patients avoid movement, as Mary Jackson did previously. This time, however, the patient finds it necessary to move around to relieve the discomfort, suggesting some constant source of pain other than diffuse peritonitis. For example, various types of abdominal colic, biliary tract impactions, or pancreatitis.
So I tossed and turned all night. I'm feeling better now, but I just don't know if I can stand that awful pain again.
We note that the pain lasted all night, but now seems to be easing spontaneously. This suggests a self-limiting process rather than one of ongoing increasing intensity evident at the patient's initial presentation.
The correct treatment for pancreatitis is first to hospitalize the patient and give analgesics appropriate for the pain. This therapy is usually accompanied by nasogastric suction and/or no oral feedings. Intravenous fluids are necessary. After the acute pancreatitis is resolved, the patient should be taken to the operating room where the gallbladder and stones are removed. Attempting a cholecystectomy while the patient is still in the acute phase of pancreatitis can result in exacerbation of the disease. In summary, our patient has presented with sudden, severe abdominal pain on 2 separate occasions, yet the management of these episodes was very different. One required undelayed surgery without making a specific etiological diagnosis. The other necessitated further investigation, and immediate surgery would in fact have been ill-advised.
Doctor, my stomach, it hurts all over. I'm not usually a complainer, but I can't make a move without it hurting. Even the ambulance ride over made it worse. The pain woke me up this morning, and it keeps getting worse. For the past few weeks, I've been having pain in this part of my stomach, especially when I've missed a meal. But that always went away when I drank milk. This pain is different. It's sharper and more constant than before. Also, even though I haven't vomited, I feel hot and queasy. Doctor, I felt really fine until last night. Then about 2 hours after dinner, I developed a sharp pain right here that kept getting worse and worse. I threw up my dinner and my medicine, but that didn't give me much relief. In fact, I thought I was going to pass out, so I went to bed, but I couldn't sleep. No matter what position I tried, the pain was still there. So I tossed and turned all night. I'm feeling better now, but I don't know if I can stand that awful pain again.
This patient shows symptoms consistent with severe upper GI hemorrhage.
I've been tired lately, much more than usual. Also, I've felt a bit queasy, but I haven't vomited. This evening when I got up from the toilet, I felt extremely lightheaded, nearly passed out. Called my sister and she brought me right over to the hospital. Don't know if it makes any difference or not, but I've been to the bathroom 6 times today, and each time my bowel movements have been very dark, black in fact. Never had anything like this before.
The patient's fatigue suggests that the bleeding may have begun some time ago. Nausea is common with GI hemorrhage of all origins, but the absence of vomiting allows us to exclude a Mallory-Weiss tear as the source of bleeding. Orthostatic syncope indicates sufficient bleeding to cause constriction of the blood volume, and melena would indicate that the origin of the bleeding is probably in the upper GI tract. In an acute emergency, the optimal diagnostic path will seek to discover the cause of bleeding without delaying proper management of the patient. The following information should be obtained quickly in order to proceed with the correct laboratory and diagnostic tests. When the patient returns to you 2 months after being discharged, he complains of almost constant epigastric pain. In a patient with vagotomy, subtotal gastrectomy, and Billroth II anastomosis, this may be due to many causes: ulcer recurrence, gastritis, esophagitis, afferent loop syndrome, and other possibilities should be considered.
I have felt horrible since my surgery 2 months ago. I have an almost constant pain in my stomach, and I have terrible diarrhea, especially after meals.
It will be important to establish the relationship of the pain to function, in this case eating, and to determine what, if anything, relieves the pain.
I go to the bathroom, up to 10 times a day, and it's always watery.
The post-gastrectomy diarrhea is common and may be due to a number of causes. We will need to know more about the nature of this diarrhea and what is contained in the stool.
Sometimes after eating, after sweet foods, I bloat up, I feel dizzy, I sweat.
Symptoms of dumping are hardly unexpected after this surgery.
And I haven't been eating much lately because, it makes my diarrhea and bloating worse. And so I'm losing weight, and I continue to be tired and weak.
Weight loss is also not surprising in view of the patient's discomfort after eating, which along with his diarrhea discourages him from eating. We should ask the following questions before proceeding with lab and diagnostic tests.
The treatment of a retained gastric antrum is to remove the antral tissue by surgery. Conversion of the anastomosis to a Billroth 1 is desirable in this particular patient because of the moderately severe dumping syndrome. Treatment with an H2 blocker would reduce acid secretion and promote healing of the ulcers. It may also reduce some of the diarrhea because hypersecretion of gastric acid may be contributing to that problem. However, this patient is unreliable. He's alcoholic and he continues to drink. Experience with patients with the Zollinger-Ellison syndrome has demonstrated that unreliable patients are probably best managed surgically than by persisting with attempts to treat medically with an H2 receptor antagonist. H2 blockers may, however, be useful in the short-term management of this patient to improve his condition prior to surgery.
I've been tired lately, much more than usual. Also, I've felt a bit queasy, but I haven't vomited. This evening when I got up from the toilet, I felt extremely lightheaded, nearly passed out. Called my sister and she brought me right over to the hospital. Don't know if it makes any difference or not, but I've been to the bathroom 6 times today, and each time my bowel movements have been very dark, black in fact. Never had anything like this before. I have felt horrible since my surgery 2 months ago. I have an almost constant pain in my stomach, And I have terrible diarrhea, especially after meals. I go to the bathroom, up to 10 times a day, and it's always watery. Sometimes after eating, after sweet foods, I bloat up, I feel dizzy, I sweat. And I haven't been eating much lately because, it makes my diarrhea and bloating worse. And so I'm losing weight and I continue to be tired and weak.